Good afternoon, and thank you for joining us. My name is Dr. Joan Reed, Dean for Diversity and Community Partnership at Harvard Medical School and professor at Harvard Medical School and the Harvard T.H. Chan School of Public Health. There are over 150 registrants for today's discussion on incarceration and its impact on health. And today's webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, DICP. The mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identify and train leaders in academic medicine and health policy, and provides programs that address crucial pipeline issues. Today's event is also sponsored by the FXB Center for Health and Human Rights at Harvard University. This co-sponsored webinar is the first event of a four-part series on medical justice and the carceral state organized by the FXB Center, the Edmund J. Safra Center for Ethics at Harvard University, the Petrie Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School, and the Medical Justice Alliance. The Medical Justice and the Carceral State webinar series aims to encourage collaboration between health and legal experts, raise awareness about health disenfranchisement in carceral settings, and showcase the material change that is possible through public interest law and medical partnerships. Today's webinar is offered through our DICP Equity and Social Justice Initiative, and it's the fifth ESJ webinar in this current academic year. In the fall of 2016, a planning committee comprised of faculty, staff, and students representing our HMS community discussed the establishment of an Equity and Social Justice series to address health disparities, social determinants of health, leadership in health systems, health policy, and other areas affecting vulnerable populations. And since 2016, there's an average of 10 to 12 programs provided annually in collaboration with our HMS affiliated institutions. These events focus on four areas: history and context, culture and environment, health disparities, and leadership and skills development. This year, our series tackles health issues that often impact disadvantaged and vulnerable populations. Our conversations and speakers will address not just defining the disparity, but also interventions, community, hospital, policy levels to address these inequities. A few housekeeping notes as we begin today's session. The chat is not available. Microphones will be muted, but you can use the Q&A to post questions to panelists. This webinar is recorded and will be posted on our DICP website. And now it's my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center and is the founder of Motivating Pathways, Inc. He's assistant professor of emergency medicine at Harvard Medical School and assistant dean in the Office for Diversity, Inclusion, and Community Partnership, also at Harvard Medical School. I'll now like to turn this over to Dr. Landry.
Dr. Reed, thank you for the introduction. Before we get started, I just want to say thank you to the folks working in the background, Mustafa, Aljani, Thomas, for helping pull this together, as well as our colleagues at FXB, including you, Veronica. It's really important that we come together and have this conversation talking about issues related to equity and social justice, really thinking about a vulnerable population, arguably one of the most vulnerable patient populations that is out there, discussing incarceration and its impact on health. I'm honored to be here to introduce our panelists. I don't want to take up much more time on my background information that I wanted to deliver, because I really think there's a lot of great content from our expert panelists that we've invited here to join us. Next slide, please. So I'm going to go very quickly and introduce our panelists. You can find out more about them on our website, where we'll be hosting their full bios. But we have Dr. TJ Ghosh, who's an associate professor of social policy and practice at the University of Pennsylvania. We have Sashi James, who's an administrator for the administrator for the executive director at the National Council for Incarcerated Women and Girls, a lead organizer. We have Jasmine Graves, who's a PhD candidate in the Department of Population and Health Sciences here at Harvard T.H. Chan School of Public Health. We have Audra Indom, who is an associate professor in the Department of Neurosurgery at Emory University School of Medicine. And last but not least, we have Dr. Monique Jimenez, who's an associate epidemiologist for the Division of Women's Health. She's also an assistant professor at Harvard Medical School and Harvard T.H. Chan School of Public Health. And so with that, we have our introduction of our panelists. I want to go straight to you, TJ. I want you to set the stage for us. Can you talk about what is the current status of where we are at as a country when it comes to incarceration?
Thanks, Alden. And first and foremost, let me convey my thanks to the Harvard Medical School and the Equity and Social Justice series. It's a great honor to be here and to be on this amazing and exciting panel. I'm really looking forward to this conversation. We are number one in incarceration. That's a dubious record. We've been number one for some time. We are number one when you come to the history of humanity. We are the most incarcerated country ever in the history of humanity. And we are number one by miles. You put the numbers 2 and 3 together in incarceration, you know, in terms of that rank order, Russia and I think it's China. I need to look at what number 3 is, but you put them together and you still don't get to our rates and the numbers in the US. And I want to just point out that this isn't an aberration. We're not number one because something really bad happened. We're number one because it is integral to the way that capitalism works, with the US being at the heart of capitalism. For us to be number one, we have to be number one in order to be the number one capitalist country in the world. And I'll spell that out in a bit. But, you know, we're here in Philly. I live in Philly, and you know, Philly is the most incarcerated metropolis in the history of humanity. We have the largest, not just behind bars, we also have the largest population of people under surveillance in the community. Because once people come out, it's just flipped incarceration. When you're under probation and parole, you literally cannot step wrong. You can't breathe wrong. You can't drive wrong. And even if you drive right, you're going to be pulled over and sent back sooner rather than later. The average amount of time you get to be on the outside if you're under probation is 3 months. So it's a revolving door, and Philly is absolutely number one in that. And I have to say that, you know, when you walk down Philly, you know, when I was, I hate to bring my arrest record in here, but maybe not, maybe it's appropriate. But when I was getting arrested in Occupy, you know, at the center in Center City in Philly, I looked up and I literally was looking down up at the logo of Aramark, which is a Fortune 500 company centered in Philly. And up to the right of Aramark was Comcast, worldwide headquarters of Comcast, another Fortune 500 company. And both these are absolutely predicated on incarceration. Aramark makes the uniforms for schools and for prisons, which is interesting, right? And actually that's a logical connection, as well as provides food for jails and prisons all over the country. And Comcast provides the dubious slight forms of phone communication, which makes massive amounts of money because it is so expensive to actually call your loved ones from prison. And they provide that, and they've built their fortunes based on the prison industrial complex. The prison industrial complex is the fastest growing industry in the US because, quite frankly, you know, politicians will fight each other in DC to get allocations for their rural communities to build a prison, because that provides dubious jobs, but it provides jobs. It also makes sure that a very, very white population in the rural, in the rural environments of the US suddenly has a massive Black community and brown community. And that proportion of Black and brown community that is forcibly moved to rural states also puts them in line for diversity funding from federal government. So certain allocated federal government that is dedicated for, counties with high proportions of poor Black and brown communities goes directly to rural communities where, it is artificially inflated because of the numbers behind prison there. So this is a massive scam. It is in the history of scams, this is the scam. Okay, I mean, it's a pyramid scheme, the likes of which we've never seen. All right, and so this is at the heart of the U.S. Economy. And I will say this, Biden came to power promising that he'd change, but in India I'm from India, we have a saying in India, which is, if a leopard promises to come into your village and start cuddling up with your pet dog, then you should be the first person eaten by the leopard. In another way of saying a leopard never changes his spots. Under Biden, Biden was the original architect, one of the original architects of the prison industrial complex under Clinton. It was Hillary Clinton, in fact, who used the word super predator to refer to young Black men who were being arrested in their time. That was what, and Obama saw the largest increase in the prison population ever before seen under any other president. And he was our Black president, right? And Clinton was considered to be our first Black president. We'll go into that. There's so much racism that is infused in that. But under Biden, who promised that he would get at the prison industrial complex and reduce it, we have seen an increase in the number of prisons. We haven't seen an increase in the population of prisons. We haven't seen an increase in the funding. In fact, he's encouraged cities to use COVID funding to hire police officers. So, and that is, again, it shouldn't surprise us, because there is no precedent who can go up and look to be the president of a capitalist country such as the United States and actually get away with reducing the prison industrial complex, including Obama, including Biden. So that's something we should keep in mind, that this is actually part and parcel of the normal way of operations in the United States. One last thing that I'll say, we gave Biden a lot of credit early on when he came in and said that from the federal side, at least, he would shut down funding. He would not renew the funding of private prisons. And everybody was like, wow, that's great. At least private prisons are shut down. Well, private prisons, there is an artificial divide between private and public prisons. All public prisons are guided by private dollars and private investments. Aramark and Comcast make their money through public prisons. And private prisons really actually incarcerate a very small proportion of the public. So along with this normal kind of economic and social operation of segregation, of new slavery, as it has been called, we have this vocabulary of we will rescue the United States from incarceration, and these piecemeal methods that actually don't amount to much, but everybody goes, oh my God, we are actually doing something, when we're actually not. We can't afford to. We literally cannot, as a country, afford to take down the prison industrial complex. And that's something we have to keep in mind when we talk about the really bad situation of affairs. So, all right, I'll stop there and move it over to the panel. Thank you very much.
It's interesting that how you brought that up, with just thinking about seeing prisons in rural communities. I'm from Texas, and I can recall going home, to visit family and just seeing a new complex, and then a few miles down the road, a new complex. So thank you for just giving us that context. Aja, I want to turn to you. Can you give us a little bit of context? We got the current status, but can you provide us some historical context to how we got here?
Yeah, and I'm so grateful that you gave me an hour to cover this topic. There's obviously a lot of different resources people can go to learn about how we got to being number one, as TJ put it. But a lot of it comes down to, quite honestly, race, and the history of race in America, the history of slavery in America, and trying to find a way to keep those systems going. TJ talked about being from India. One of the interesting things, I was just going back and rereading the New Jim Crow again, and looking at that and the book Caste. It's interesting how much the term caste comes up when one talks about the criminal justice system and what's been set up here and the reasons that it's been set up in this way. And a lot of people are familiar with the idea of the caste system in India, and kind of separating people up from kind of the highest heights of society to the bottom, the untouchables, and trying to put people in their place in a way. And there's kind of a quasi-religious way that that's done in India, to my understanding, from the readings that I've done. In the US, what we use is race to put people in their place. And, back in the day, for a long time ago, it was actually very easy to do that and just say, okay, Black people need to be at the bottom, and everybody kind of understood that. But at the end of slavery and kind of moving forward into Reconstruction, and when Jim Crow laws were brought up, they needed a different way. It became a little bit less okay to just say we're going to keep Black people at the bottom of society, and for everybody to agree, well, yes, like that's where Black people deserve to be, and we needed to find, that being the United States, needed to find a new way to keep the caste system intact. And in some ways, it was quite ingenious. At times when actually crime was quite low in the United States and drug use was quite low in the United States. Ronald Reagan in the 80s came up with the war on drugs. This actually, that war on drugs predated the crack epidemic. And, obviously, again, in 3 to 4 minutes, I can't go into the CIA and Nicaragua and how the drugs were getting into inner city neighborhoods in the United States. Clearly, people who were impoverished in these various cities didn't have planes to go and fly the cocaine into these communities. But nevertheless, we started to perpetuate this war on a crime that, again, hadn't really even reached its heights way back at the beginning of the 80s, with the sole purpose, really the express purpose, of increasing the prison population and creating this class of people who had been touched by the criminal justice system in some way, jailed at some point, whether they are then on probation or released afterwards, and then allowed to treat them as second-class members of society. And when you take such a large proportion of the Black community and run them through the criminal justice system and treat them as second-class members of society, it makes it a lot easier to even take those that haven't been directly touched by the criminal justice system and brought through the criminal justice system in that way, and also treat them as second-class citizens, keeping that caste system intact from all the way from the days of slavery to today. And I'll say, again, just like some of the things that TJ said about capitalism and the criminal justice system, this one might say this allegation of the caste system and the criminal justice system being so tied is going to be very forcefully rejected by some people on first hearing. And again, we have an hour and a half. We don't have time to go into all of the history and how we got here, but I would really strongly urge you to try and go back and read some primary sources about how we went from increasing our prison population in the way that we did, from 300,000 or so in the beginning of the 80s to over 2 million now. That takes some thought and some deliberate action and a desire to keep the system in place.
Thank you, Aja. You're right. I mean, that in itself, the first two questions are really panels that we can have, and it's purely on those topics. And I would ask the audience to really be thoughtful in sort of where you get your source of information to do your research, because really it takes some unpacking to do, and you can't get to the heart of these issues with a 4-minute answer to a question that's posed by a moderator. But you did a good job, and I appreciate the context that you gave us. And I think, one of the things we have to do as a country is really grapple with slavery and how that continues forward to where we are at as a country today. I want to turn to you, Monique. What are the real life implications of both our country's historical approach to incarceration as well as the current status on an individual level? And to dive into that a little bit more, what are the challenges on collecting data when it comes to incarceration, specifically on an individual's impact on health?
Yeah, thank you for that question. And again, thank you for the opportunity to be here. And I just also want to take this opportunity to, provide a face. So for example, TJ presented his experience. I'm also the daughter of a formerly incarcerated man, a very proud daughter. And so I think it's important for us to realize that when we talk about incarceration, we talk about carceral control, we're talking about all of us. This is not a them problem. This is an us problem. And I just want to affirm, what was shared before, and sort of, we can't think about where we are today without fully really embracing where we came from and understanding that those systems of oppression that have been intentionally built within the fabric of our country have intergenerational ramifications. And so there's no way to really pull any of that apart. And so one of the clearest ramifications of that is that we have egregiously disproportionate rates of incarceration in the United States. So we know that the rates of incarceration for Black, Latino, and Indigenous people in this country are, several fold times higher, 6 times higher than that of the white population. There's also really important to recognize that there are differences as well by sex. We don't have very good information about gender, but I can talk about sex using that. Grounded within sex here in this space tends to be based on the type of facility that an individual will be sent to, not necessarily their gender. And so we have these differences by sex, we have these differences by race and ethnicity, and we have differences by the intersection of them, in addition to other intersectionalities. So historically marginalized populations living in multiple domains, because none of us is just one thing or another. They are layered upon one another. And so what this leads to on an individual level was touched on before, is that the experience of incarceration itself is not the end of the conversation, right? We actually are seeing this, the exposure to the criminal punishment system, we can argue is in utero, whether or not the parent is themselves incarcerated. We have very strong evidence to demonstrate the really harmful impact of exposure to having a family member incarcerated, even if that's not an immediate family member. In addition, we know that it hurts communities as a whole, because as was shared previously, we have some communities where the majority of the male population is behind bars. So what does that mean for the economic viability of communities? So the entanglement of the carceral space, the economic, the social ramifications on the individual and community level they're so intimately tied. And I think in particular for our conversation today, it's important for us to understand the perverse entanglement of the carceral system with respect to the systems that we consider to be social support services, right? So for example, child and family services, education, and medicine. They are all perversely entangled with one another and become systems of surveillance, so that very often they're not protection services and not support services, but actually can feed people back in to incarceration. So we have to consistently bring ourselves back to that. And I think that one of the challenges is, through that historical context, these systems have been crafted. They didn't evolve, they were designed to ensure data opacity, and they were designed to function with impunity. And so that allows for a lot of the egregious issues with respect to healthcare to be perpetuated. And so although we have mandated access to healthcare, it's really rooted in a reaction to not allow for cruel and unusual punishment. And that has long-term ramifications for those who are inside and also once they're out.
Well, I have to keep my camera on. I mean, my microphone on mute because I'm just and amening over here. And I see Jasmine nodding her head a lot as well. So I think we're all sort of really in that same space when it comes to this conversation. Sashi, I want to turn to you because I think you are coming at this from a boots on the ground level. Forgive the metaphor, but based on your work with the National Council for Incarcerated and Formerly Incarcerated Women and Girls, and with Families for Justice and Healing, as well as your own personal experience, can you tell us the impact of incarceration on the well-being of families, especially on children of incarcerated parents? And I think Monique led with this, and I hope that you could drive that point home a little bit more.
So my name is Sashi, and thank you. I'm a daughter of formerly incarcerated parents. My dad served a chunk of time, and my mom also served a chunk of time. But what that looks like is, I always make a joke, is that, I never knew what Father's Day was until my father came home. And unfortunately, this is the culture in our community. And so like Monique said, When parents go to prison, nobody talks about daughters and sons and their children going to prison as well. Nobody talks about that 2-family household, which is now a 1-family household, who was already struggling when we were a 2-family household, now has to figure out how to provide with only a mother. And also, and more importantly, nobody is talking about that over the last 10 years, there's been a 700% increase of mothers now being incarcerated. So who's going to raise the children in the community? And so that's why Families for Justice Healing, that's where I represent as the National Council for Incarcerated and Formerly Incarcerated Women and Girls. Our goal is to end incarceration of women and girls and provide the infrastructure, which is reimagining communities, so that way we can invest in the community, so that way we can create the diversions, so our children never end up incarcerated, right? We can definitely end incarceration of women and girls, or just end incarceration period, if we invest in a generation, just one generation. We can really create a better future. And like my brother said earlier before Monique, this is a culture, right? And we need to, in order, but beyond reforming, we need to dismantle the culture of incarceration. We need to dismantle the system, so that way we can really put the people first. The system has already been stealing our fathers. The system has been creating more homelessness, creating more poverty, and it's just feeding us. It's taking all of our energy out of us, out of the life of us, after we have already been trying to survive. That's all we're trying to do every day. Communities that are over incarcerated and under resourced are just trying to survive. And then when you have a system that is a multi-million-dollar system that's forcing you to pay for phone calls just so you can speak to your father, who you haven't even seen in decades, it's taking you down piece by piece. And then you have organizations like Families for Justice Healing that are trying to spend their micro dollars to build these people back up, so that way we can create a better future. And so that's what it looks like to put the children first. I'm a daughter. I advocate every day. I'm sure y'all seen my daughter, just like her head walk by, but she's the reason why I do this work. My mom is the reason why I do this work, because when my mom came home from a prison, when she came home from Danbury, as long as her other sisters, she didn't just come home and say, okay, we're going to pick up the pieces and move forward, but she came home and politicized us and educated us and said, yes, you live in Roxbury, but it's not just Roxbury. You live in an open air prison. So when there's cameras on your corner, when there is a police cruiser that driving down the street, they're surveilling you. And that's not right. That's not the lifestyle that we deserve to live just because we live in Roxbury. So, our goal is just to really put the people first. And that's all we need to do.
Thank you. And I think it's, really framing it as it's not just the individual who is in prison, but their families and the children and the multi-generational component to this, because of the economic setbacks, the educational setbacks, the growth opportunities that are lost, really puts this all in perspective. And it's not just that one individual that goes away and does some time and then comes back and can start over. It really is fracturing communities and having multi-generational impact. And I want to turn to you, Jasmine, because I think you really focus in on a specific component of incarceration in some of your work. And you recently testified to the Massachusetts State Senate regarding solitary confinement. Can you tell us a little bit more about this practice specifically, and then how widespread is it in prisons and jails?
Yeah, no, absolutely. I mean, first, I have the spirit of an old church lady, so I'm absolutely over here being like, yes, amen. Oh my God, my spirit is full already. And before I get to your question, I do just want to put a fine point on two things, because it really strikes me again. I really appreciate how Dr. Jimenez, brought very clearly into the space that, like, we're not talking about people over there. And I just wanted to offer that, like, I also am the niece of somebody who was incarcerated for 10 years and had to bail my own father out of jail when I was in college. So he experienced local jail incarceration a couple of times in his life. And so I think it's just interesting that out of a panel of 5-6 people, half of the people here are family members and who've been directly impacted by incarceration. So I just want to kind of put a fine point on the human impact that we're talking about right now, just even in among the 6 of us or 5 of us, however many people I think are here, if I can count. And then I also really appreciated the historical and present day context offered. I just want to, quickly also lift up that, like, when we're talking about this system, it is a system that reflects racialized capitalism, as TJ offered. And that is one that, like, certainly evolved and started from the point of enslavement. And to kind of, support those points offered, I just wanted to drop in the chat for the audience an article that Dr. Khalil Gibran Muhammad, who is a historian and a professor of policy at the Harvard Kennedy School, just recently published in January of this year. And it very nicely offers a very clear and succinct timeline that argues just that exact point of the kind of racialized capitalism being the root of incarceration in this country, and that it actually does not start. Mass incarceration, we can point to, the 70s and 80s, but the just practice of the carceral system and the criminal punishment system dates all the way back. So, really not just the 19th century, but arguably the 17th century. It is heavily racial. It is not heavily racialized. That is just what it is. It's not like, you just add race to it. That is the foundation. Okay. So before I kind of get into, some of what I was offering up in my testimony and talking about the experiences of people in solitary confinement, I just want to offer a little bit of context for the work that I'll be referencing in our conversation today. So prior to coming back to school, I worked in New York City government for about 8 years in various roles and capacities. And, work in our local jail system really kind of is situated at the bookends of my career in New York City government. So I came in as a qualitative researcher working at within the Bureau of Correctional Health Services, which at the time was at the New York City Department of Health and Mental Hygiene. And my full, job at that point in time was to document cases of brutality that people on the island or across New York City jails were experiencing, the harms of solitary confinement, issues of dual loyalty. All of these things can just, all be kind of conversations in and of themselves. But again, this issue of like, what does it mean to be a medical doctor or a medical practitioner and have loyalty to your patient, but then also be in a security apparatus where you have loyalty to correctional officers and, the correctional system, essentially. How does that impact the quality of care provided? So, as my colleagues, we're managing, the contract with our private prison health corporation, as they were kind of like conducting these quantitative analyses, it was my responsibility as the qualitative researcher to go in and actually sit with people, cell side, sit with people in clinics to really understand what is the human experience that we're quantifying and that we're testifying and kind of putting a face to at hearings, in media, but then also in our day-to-day work, which was to oversee the quality of care provided to people who are incarcerated. So that was like the start of my career. And then the end, I was serving as a senior policy advisor at the mayor's office. And interestingly, Correctional Health Services was in my portfolio, so I was responsible for that oversight as well. So I just want to give some context for like the, the experiences that I'll be referencing as we're in conversation today. So the testimony, and I get a little slap happy with links, so forgive me to all the audience members. I'm not gonna like speak to in detail, but if you'd like to read it, there's the link there. And the vast majority of it, I'm just drawing on, kind of our findings, from the period of like 2011 to 2014. So just kind of really quickly, solitary confinement in and of itself is often a punitive practice and management strategy utilized in jails and prisons across this country. Generally, people will say like, oh, it's, if someone receives an infraction or a sanction of sorts, or if they're labeled a problem, or if they are, considered to be vulnerable to experiencing further harm in the facility, those are all kind of justifications that are used and reasons why people are placed in solitary confinement. Solitary confinement as a practice is being, held in isolation, held in a cell for 23 to 24 hours a day for, days, months, weeks, even years on end. And these sanctions and the reasonings for it can range from like getting into a fight to having a cell phone because, it's really expensive to contact your family, or, it's really expensive for your family for you to contact them. Maybe you just want to connect with other people. There are a lot of reasons why people get cell phones in facilities, to even having condoms. Having condoms and trying to practice safe sex is also criminalized within the facility and can be a reason that a person is put into solitary confinement. And just to kind of like offer, just again, a quick story or sense of how long, in this country people can stay in solitary confinement or be placed there, I think it's really important to lift up and remember the experience of Albert Woodfox, who was incarcerated in Angola, which is a Louisiana state prison. And during his period of incarceration, he was held in solitary confinement for 43 years, which is insane for me to fathom as someone who's 32, that like you spent 43 years of your life just in solitary confinement. So that's just to give you a sense of how excessive and brutal the use of it is in this country. I think it's also important to note that along those lines, the UN Special Rapporteur, Juan Mendez, in 2011 regarded solitary confinement as a practice that is recognizing it as torture and cruel and inhumane treatment of human beings, citing the severe mental pain and suffering that the practice causes. And there's a wealth of research that supports that assertion, including our own research in New York City. And from that recommended that, if the practice were to occur, it should only be for 2 weeks at a time, which in actuality is far too long in and of itself. Any hour, day is far too long. A number of formerly incarcerated activists often encourage people to imagine being locked in your bathroom for days on end, months on end, years on end, to even get a semblance of the experience of being put in solitary confinement. Because the truth is, it's not just you being isolated in yourself, but it's also the environment that those solitary units kind of create, And I'll speak to a very specific example in New York City in a second. But what we found in our work that kind of tracks with the research that Juan Mendez put forward, and kind of exploring the relationship between self-harm and solitary confinement, we found that people who were held in solitary confinement were 6.9 times more likely to engage in self-harm, and even far more likely to engage fatal acts of self-harm. So that was kind of like my colleagues who were running our different regression analyses, identifying these patterns. And so then it was my job to come in and actually speak to people who had histories of self-harm or who were currently engaging in self-harm to understand what was happening to them. And I'm not going to speak to like a specific person because I feel very strongly about protecting the stories of people who were courageous enough to share it with me. But I will share a very public and tragic experience. And you have to forgive me because I get a little emotional, just quite frankly, talking about some of these experiences. But I think that a really poignant and powerful case to point to is the story of Jason Echeverria. So in August of 2012, Jason, and let me just take a step back and say there was a lot of activism in New York City, and for a long time, not just in 2011, to push the Department of Corrections to pull people who are living with a mental illness out of punitive segregation, which is generally what Corrections Department will call a solitary confinement unit. And so the Department of Corrections said, okay, we, after lawsuits and various negotiations, we'll pull people with a serious mental illness or people who on the island we said had an M status out of solitary confinement, and we'll put them in a different unit. And so, what they really did was create a solitary confinement for people living with a mental illness and call it a different name. At the time it was called the MAUI, which stands for like Mental Health Assessment Unit for Infracted Inmates. And so, what we found was that like that unit literally mirrored the punitive segregation unit down to like just the physical layout. Everything was exactly the same. The only difference was that we ensured that mental health practitioners were available on site to be able to pull people out of cell and speak with them. But truly, again, this is the security apparatus runs the show. And so the actual management of the unit was the same as the punitive segregation unit they were in before. Nothing really changed. And in fact, we found that there were higher rates of injury in this new improved unit than there was in the former unit. So Jason Echeverria was placed in this unit. He was 25 years old. What we found is that, again, a lot of people were engaging in self-harm. What officers would often do is give people soap packets to clean their own cells, because there are also issues of people decompensating and smearing themselves in feces, smearing the cell in feces, just to kind of give you a sense of, the intensity of the torture that people were experiencing and how they were reacting to that environment. So people would be given, you know, soap to clean their own cells just on a regular basis, especially in instances where they're not doing well. And so what we found is that people would sometimes swallow those soap packets as a way to, like, you know, I can't live like this anymore. B, I know that, like, the only way out of solitary confinement in the New York City jail system is to gesture an act of suicide, or to engage in some act of self-harm. That is literally the only way out of getting out of solitary confinement. So Jason swallowed soap. He started to vomit uncontrollably. Our pharmacist was rounding and, you know, dispensing medication, and she let the officer know, hey, this person doesn't seem to be doing well. You need to take them to the clinic. He encouraged our pharmacist to keep going and, like, don't mind it. Someone else will handle it. She let the officer at the bottom of the tier know before she left, hey, that person in cell XYZ is not doing well. You all need to get him to the clinic. Don't worry about it, we'll handle it. The clinic was never called. In accounts of people in cells surrounding Jason, they heard him screaming out for help. They heard him vomiting and choking uncontrollably. This is like around 6, 7 o'clock, and by 8 a.m. the next day, Jason was dead. So I just share that experience to offer the weight of what people are experiencing, even just in local jails, in solitary confinement, and to share that that experience is, like, one that his family will forever live with, and not just his family, but everybody who had to hear Jason in nearby cells choke to death and literally be burned from the inside out for ingesting soap, and kind of experiencing that medical and, you know, medical neglect that's really facilitated by the correctional officers and folks in the facility. So I hope that kind of answers the question and gives some context to what solitary confinement is, what it does, its impact to individuals, its impact to families, and really the impact to other people who have to witness it and also experience it in the facility.
Thank you, Jasmine, and thank you for just being honest and sharing your emotions and your experiences in this space. So we are going to maybe transition our next sort of subset of questions in this panel, because I really want to start to dive into the health aspects of this all. You know, we typically approach our equity and social justice lecture series with an angle towards health and health justice, and I think that is a good sort of next segue, and then we really want to focus the last part of our conversation on the reforms or the changes, or even taking it further into the deconstruction of the prison system to wrap this conversation up. So we have the background now. We're going to talk a little bit more about the health aspect, and then lastly the change that needs to be made. So going back to you, TJ, can you talk about the impact of incarceration on a community and a society?
Thanks, Alvin. Yeah, you know, Pennsylvania spends $42,000 a year per inmate, you know, per person incarcerated. So that should give us a sense of exactly how much is required. And that's on the low end, because, you know, when you're coming into Philadelphia and into the higher, you know, cost of living, where food is more expensive, it's just a lot of money that we as a country spend that could be better spent. I mean, you give a person $42,000 a year for a job instead of going to prison, you're actually going to get an amazing benefit to society, right? And not only that, about, you know, a large proportion of our prison population is there because of substance use. This is especially true for women, as has already been mentioned. You know, that is sex work and substance use, both of which are linked, are the single biggest pipeline into prison for women and for many young Black and brown men. And if you spend $1 in treatment, in substance use treatment, you actually not only do you get that money back, you get that money back, you know, more by a factor of 11. You literally get $11 back in societal costs. So the massive disjuncture, it doesn't. So, you know, people think capitalism makes sense economically. It actually doesn't make any economic sense to incarcerate, because capitalism has no economic rationality to it. It is absolutely the most wasteful system of economics. And I think that we must understand that the health costs of incarceration are massive. Today, during these COVID times, for example, prisons have had the highest population of those getting infected and dying. The rate of death in the US due to COVID is the highest in the world right now. And it is literally 4 times, 3 weeks ago, it was 4 times the rate of the second in line there. That was Russia. Today it's gone, Brazil has caught up and is in second place, but we are way ahead. And it's not people who are rich or well off who are dying because they have, even if people are getting infected at very, very high rates, the death rate for COVID is entirely being experienced, not entirely, but predominantly being experienced by poor Black and brown communities, a large proportion of whom are circling in and out of prisons. And we don't get to see that. That's why we think COVID is kind of okay, manageable. We're on just today, we had an email come out from the Penn provost saying, hey, restrictions are off. We're going down in numbers. Actually, Penn's numbers, and this is true for almost every campus, are way higher than Philadelphia's. But we don't really suffer as Penn students or faculty because we're vaccinated. But we're engaging with poor Black and brown communities who are coming out of prison constantly in West Philadelphia, one of the most incarcerated communities, and many of whom are, because of various reasons, are not vaccinated, do not have access to healthcare when they do get infected, and are dying at 30% higher rates than the US rates. So poor Black Philadelphia has probably one of the highest death rates in the world right now because of COVID. And that is entirely connected to incarceration. And the fact that we don't see the health effects, we literally segregate ourselves away from the actual death effects of pandemics like COVID. When they spike, guaranteed it's people in prison and people coming in and out of prison in our communities who are dying at higher rates than anywhere else in the world. So I think it's a massive problem. I think it's one of the problems that we will be judged by future generations for saying that at a rate today where the US rates of COVID are higher than 85 new cases per 100,000 per day, 85 is the cutoff for absolute stay-at-home orders everywhere else in the world. We are still at 130. A week ago, we were at 300. And those are experienced by Black folks and brown folks who are coming in and out of prison. And we just do not acknowledge it. We do not acknowledge it. And that is what incarceration has done to us. It has put metaphoric and literal blinders to the public health situation in the time of a pandemic, where we are comfortable with a pandemic now saying, oh, it's okay. The provost of University of Pennsylvania and of Harvard, and everyone else, it's okay, back to business, when actually we are directly infecting people in our communities because of this. So that's something that we really need to deal with as we move forward as a generation.
Thank you. And Aja, we're talking about this conversation, and this isn't something that's part of a typical conversation for physicians, nurses, and other healthcare workers. And so I guess my question to you is for a doctor, for a nurse, for a pharmacist, for an optometrist, why does this matter? And to carry on with that, do you think healthcare providers need to shift how they think about their professional relationship with the criminal justice system? And I think part of this was partly answered, but I really want to get your perspective, especially with some of the work that you do.
Yeah, thanks for that question, because it gives me an opportunity to explain why there's a neurosurgeon on this panel, which could be very confusing for a lot of people. So I'm going to try. So I'm actually one of the co-founders of Physicians for Criminal Justice Reform. My co-founder and I, and Zinga Harrison, who's a psychiatrist, which that makes a lot more sense, right? So if she was here, you get that quicker. But one of the talks that she put together that I found very useful was to talk about medical ethics and the principles of medical ethics and how they apply to this, which I believe is the biggest civil rights issue of our time, which again, I was fortunate to have seen a talk by Michelle Alexander talking about the new Jim Crow before I actually had an opportunity to read it and had my eyes open to why this was. And for me, in my journey to this, really is like everybody else looking at cell phone videos of Black and brown men dying at the hands of the police over and over and over again, and sometimes not at the hands of the police, right? Because one of the biggest ones that was in the news was Trayvon Martin. We didn't have a video of that one. But there was a common thread, and the common thread for all of those for me was this assumed criminality of Black and brown people, and then the loss of autonomy. So patient autonomy being one of the foundations of medical ethics, right? The idea that you're going to be able to create your own destiny and make your own choices in your life and in your healthcare. That's critically important to medical ethics. It's foundational. And if we want to make sure that our patients, that the community that we serve has autonomy, then we have to attack mass incarceration and pursue criminal justice reform as medical professionals. If we want to talk about the concept of non-malfeasance, that we're not going to harm the people that we're taking care of, right? That we're not going to participate in systems that are perpetuating harms upon our communities. Then we have to care deeply about criminal justice reform and mass incarceration. Because again, if we participate in a society, if we are healthcare providers that are willing to provide medications for the death penalty, right? That's clearly not consistent with the principle of non-malfeasance, right? If we are providing healthcare knowing that the healthcare that it gets provided to people that are incarcerated is inferior, that does not adhere to the principle of non-malfeasance. And then there's, on the other side of this, beneficence, right? So we have to help people. That's the whole reason we're in healthcare. Again, another foundational part of medical ethics. And if we know that a large portion of our community has directly been brought into the criminal justice system, or as was so eloquently stated, the families and the communities around them missing the people that have been taken into that criminal justice system. And even when they come out, I mean, it's not like you come out and, while there are ban the box initiatives and that sort of thing, it's not like after you're formally incarcerated that the stain of that just wipes away. Your ability to participate in all of society is harmed. And so again, if we're going to help our patients in the communities that they live in, then we have to care about criminal justice reform. We have to care about mass incarceration. And then the simplest one, obviously, the fourth pillar is justice. What's fair? What's fair to happen to the people that see us every day? What's fair for the communities that rely upon us, that look upon us as leaders? And one could say maybe during the COVID-19 pandemic, some sections of our society maybe look less upon us as leaders, but still, as healthcare professionals, we hold a position in society where people tend to listen to what we say, thinking that we're talking about the things that are in their best interests. And so if we're not talking about this, knowing the harms that it's perpetuating on our country, on our community, on the society that we live in, then how can we call ourselves ethical medical professionals, which I would think that we would all assume ourselves to be. So this is, to me, foundational to medicine in this day and age, that someone that is involved in healthcare needs to know that this is an issue and needs to be speaking up about it.
Thank you. And I think you really drive it home with the tenets of what healthcare is founded on, what medicine is founded on. Because if we're not thinking about it from that perspective, then we've completely missed the mark of why we even chose this profession in the first place. So thank you for that. Monique, now that we got the background of why this matters, can you tell us what healthcare actually looks like for those individuals who are incarcerated? Who pays for it? How does their health status compare to that of the general population? Give us a picture of what we should be expecting to see for those who are incarcerated.
Sure. Thank you for the question. I think I'll reiterate what was stated before. In the US, incarcerated populations are the only mandated population that has a quote unquote right to access healthcare. But I think contrary to what the general population may believe about that, is that there are consistent and very intentional barriers to accessing that care. And that mandate is not rooted as a comparison to the standard of care. That mandate is simply as a reaction to cruel and unusual punishment, which means that the mandate is only for adequate care. It is not for the standard of care. And that is a really important distinction. So I'll name a couple of just these very basic barriers to even accessing care for incarcerated people. For example, when somebody wants to receive medical care, they need to fill out a sick slip and request that care. So who does that go to? It generally goes to the guards. So what we see across carceral systems, and again, we have a very decentralized carceral system in this country. There is no one oversight body. Local systems are run by local systems and each one is different. And state systems are run by their states and each one is different. And the federal system is run by the federal government. And so there's so much variability. But what I'll say is that we see consistently guards being the first gatekeepers to accessing medical care and often making decisions about who deserves that care, irrespective of the fact that they are not medical professionals, right? So that's one piece. The other thing to keep in mind is that this, has been touched upon by many people, is this intersectionality of the funneling of individuals into our carceral system. And so filling out that slip in and of itself is a barrier for many individuals who have low literacy. For individuals, for example, who may not speak English, or who may have other sorts of conditions that would impair their ability to do so. And so I also want to highlight the incredible amount of resilience and culture of strength among people who are in these spaces to support one another. I've talked to countless women and men who were the self-designated, the go-to person to help people fill out their sick slips. And so we have this barrier there. We also have a barrier that a lot of people don't realize is that in many states or systems, people are required to pay a copay. And so that copay may be crafted as like, oh, it's only $3 to $5. But when people who are working make only pennies on the dollar a day for their work, the translation of that to what that actually costs an individual is exorbitant. It's astronomical. And so who does that fall upon? For people who are lucky enough to have family support, that cost falls upon their family members. So these are just two very basic examples of how these systems are crafted to even prevent that mandated access to substandard care. And then I also just want to highlight what was shared before by Jasmine with respect to the operational safety protocols. And so this excuse of something being a violation of safety can be employed whenever systems or actors within those systems want to. There is no burden of proof that something is going to be a violation of safety. So if somebody, let's say, needs to be transported to a specialty visit, if that's going to be considered to be a violation of safety or the facility is on lockdown, that person is going to lose out on their care. And it's going to create another, either complete withholding of care or severe delays. And so I also just wanted to kind of highlight is that we have from 1965, the inmate exclusion policy which prohibits Medicaid from providing payment for services for people who are incarcerated, with the exception of in-hospital stays. So within our general population, a lot of the safeguards that we have around standards of care are because of CMS reimbursement. And because carceral systems do not pay for their medical care in that way, they are paid by the institutions themselves, there is no oversight. So there's no required accreditation. There is one voluntary accreditation body, but again, that is voluntary. So what that allows is for, as was shared earlier, the proliferation of for-profit healthcare within carceral spaces. So even though most facilities are not private, the provision of care is almost exclusively provided by private companies across the country. And these are for-profit systems that have a benefit in providing the least amount of care possible. And I just also, wanted to touch on your question with respect to what does the healthcare look like? Or what does the health profile look like for people who are incarcerated? And on average, we see very complex patients within carceral spaces. And so very often our jails are the first line of mental health care. And so we have complex patients. And here we get back to, data opacity. We don't have great data about the health of incarcerated populations because our large national surveys like NHANES, for example, that gives us really important information about the prevalence of obesity and diabetes and hypertension exclude incarcerated populations. And so we are relying on data from the Bureau of Justice Statistics, which at this point, the freshest data is from 2016. So we do know that the prevalence of chronic conditions is exorbitantly high, about 50%. It's higher than the general population. We see higher prevalence of asthma, hypertension, diabetes, all of the types of things that we associate with having, vulnerability and lack of resources. So we also know that that prevalence of chronic disease and complex mental health conditions is not just shaped by the experience of incarceration, but also those pathways that funnel people into incarceration. And then the experience itself is plagued by limited physical activity, high sodium diets, and a highly stressful environment. And so these are all things that contribute to also the fact that over 90%, I think it's maybe 95, 98% of individuals who are incarcerated are going to be coming home to their home communities. So that means that we have people coming back into the community with very complex medical needs who have been likely re-traumatized by the healthcare that they received while they were in the carceral system. And I'll just end with some statistics that we have from Massachusetts. For example, in Massachusetts, 30% of people in male facilities and 76% of people in female facilities have been identified with this serious mental illness.
Well, and I think about this from a provider perspective. As a physician, when I'm working in the emergency department, I see patients coming in from some of the facilities around Massachusetts. They're in my emergency department because there's an issue with their fistula for a dialysis, or there's an issue related to some really advanced oncologic process. And one of the driving points that I try and make with my trainees when I'm working with them is, when you have someone who's incarcerated for 20, 30 years, they may not necessarily be getting all of that maintenance screening that an individual who has a primary care provider who can go freely to see their PCP whenever they want, they're going to have. And guess what? Those individuals get cancer. Those individuals don't necessarily get their colonoscopy and end up with that colorectal cancer that could have been caught much earlier. And it's problematic. And I think it's, again, driving home what I'll just point was, thinking about why this matters to us as physicians is because we are caring for these individuals. And oftentimes these are preventable issues that we're caring for, not just the mental health component. And I apologize for becoming a panelist and not just maintaining my moderator role. But when I see this, it frustrates me to no end, because I'm caring for these individuals in my emergency department when they should be receiving this care in other places. More importantly, they should be receiving much better quality of care. All right, I'll step back because I want to make sure we have a chance to hear from our esteemed panelists. Sashi, how does incarceration impact the health of women, and maybe driving that down, even thinking about girls in particular?
Cool. And I also wanted to just share love to Jasmine, because I know how hard it is to lose a person that's incarcerated, especially when you're advocating for what people need and nobody's listening to you. So I just wanted to just give you some love, because I know how hard that is, especially because we just lost a sister who needed substance use into diversion, and they incarcerated her in South Bay. And the next day she was found dead in her cell. And so time and time again, our people are going overlooked and never heard, and they're just dying inside of a cell alone. And now we have children in the community that does not have a mother, because we needed treatment and not incarceration. And so what does that look like? I feel as though to the public health, I feel like we have to go back to the basis. And that person and that mother died because she wasn't viewed as a human being. And that's what the culture of incarceration does, which labels us as inmates or just gives us numbers. And they don't look at us as people or a mother or a father. They just label us immediately, and it devalues us as a human being. So when we need treatment, or when we need help, or when we just need a conversation to ask, why are you even in prison in the first place? We don't get that, because people are not asking those questions, because they don't have a vision of us as being a human being. And that drives us all the way into the community. So even when we get out of incarceration, or when we start talking to our children that were impacted by our family's incarceration or the help of incarceration, we're gang members, baby mamas. I mean, if you read Eddie Ellis's letter about language, it drives us all the way home to saying, like, we're going to start to outlive those labels, right? So when you call us a gang member, I'm going to automatically start to think that I'm a gang member, and that's how I'm going to live. But so that I feel as though as healthcare providers, as when we talk about DOC, we have to really break that culture down so that way people are viewed as humans, which will bring us all the way to the community. So that way we can really build up the people in the community. So that way they're not carrying that culture of incarceration, right? But then I wanted to also go back to how important it is for public health experts to advocate for women and girls that are incarcerated, because, time and time again, I know our sister who just came home from doing decades inside of Framingham, but the moment she came home, she found out that she had colon cancer. And like you said, if she had her gynecological appointments and all those doctor appointments were on time, she would have been able to treat that cancer way before it even hit stage 3, right? And so this is what's going on in our community. If you're going to lock a person up in a cage, you're now responsible for the health of them, right? And if you're not maintaining their health, you're failing our people. People are sentenced to incarceration, not death. And that's what's happening in Massachusetts, right? People are dying. And just because a person doesn't die inside a prison, and if a person comes home and 3 months later they're dead, that's because of the prison. And that's why it's important that we, public health people, public health experts, all of us have to educate and use our platform. And I love SXB because, we have our private calls and, we're like, this is what we need to do. But this is why y'all are important for us, right? And this is why all of the health that is, when we talk about incarceration is a public health crisis, because everybody in our community feels at one time, and I'm going to say this from a personal perspective, at one point in my life, I felt like I was going to end up incarcerated. And I realized that that's not my future. That's not my daughter's future. And any young woman that comes in contact with me, that's not going to be their future either. And if you're working under the model of reimagining communities, that's not going to be your future at all either. We can really do this if we work together. And I'm just going to just leave it there because I am upset that we only have an hour and 30 minutes to have this discussion. But, and I did want to say, one thing of the harm that happens inside, and this is a real life story, but when my mom came home, she made a joke because it's talked about Monique and how people are getting paid pennies just to do their work, and then they want to charge you for stuff like tampons and pads, and if you don't have family members, how can you afford that? So I remember when my mom first came home, she probably would kill me if she knew I repeated this, but she said that they used to make they give you free pads and they would roll them up and use them as tampons. And so what kind of system are we allowing to treat women like this? For you to not provide a woman with the proper sanitary products that they need so that way they can just live their regular life. I mean, this is why we need to dismantle the system. And I'm gonna just pause right there, but I just had to share that.
Thank you, Sashi. And I apologize that it's only an hour and a half. We can only keep our audience for long. And more importantly, we can only keep you all for so long. But it's great that FXB is going to continue on with this conversation. So I just want to make sure that for our panelists, we have probably about 20 minutes to go. So I really want to try and get through with the last few rounds of questions. So just be cognizant of your time as you're speaking. Jasmine, I want to go to you. When it comes to the criminal justice reform work, in the context of the municipal health department, what are some opportunities? And so what are the challenges that we're dealing with?
Yes. So I should be upfront and say that I came to public health with the intention and the commitment to leveraging its tools, its language, theories, frameworks to engage in jail and prison abolition work. So I do not subscribe to reform. And in fact, interestingly, though, I have colleagues who would certainly disagree with me. Much of our work at the health department, and I would imagine, and I'll make this clear in a moment, now at H&H in New York City, much of the kind of research that we did, what we saw in our work on Rikers Island and throughout the jail system, was that reform actually is many ways becomes just a kind of term that gets co-opted to then characterize just another iteration of the same thing. So I used the example earlier of like the punitive segregation unit becoming the Maui. That was considered a criminal justice reform success. That was a win, but in actuality, it was just the same thing. So it's, so interestingly, my time kind of working in reformist spaces only further substantiated my beliefs and kind of commitment to abolition because, yeah, and I'll try to spend more time in our last round making a case for that, because that's not your question. All right, so municipal health departments. So interestingly, New York City is, I think, perhaps the only jurisdiction in the country that has a local health agency do the kind of oversight of medical and mental health care provided to people. As Monique mentioned, like much of the provision of care is provided through a private prison health corporation. And we certainly engaged in that up until, I want to say 2015, we contracted with Horizon. But the oversight of that contract was the health department. It was through the Bureau of Correctional Health Services. So that's one mechanism. Right, that municipal health departments can engage in, right, is being that kind of direct oversight or the agency that provides the direct care to people who are incarcerated. And through that oversight and responsibility for, providing quality care to people, that is, there's an opportunity, certainly dependent on the leadership's orientation, to also be making a case about the harms of jail, right? Because literally there's no, in my view, and we'll get into this in the last round, such thing as good correction. There's something about putting people in cages and giving other human beings power over them that will always create corruption and chaos. So now in New York City, the Bureau of Correctional Health Services, I want to say, is now the Division of Correctional Health Services, which is actually at our public hospital system. So that's another kind of arrangement that like a health agency can engage in. And now that it's at H&H, which is the public hospital system in New York City, the provision of care is directly, we're not contracting to a private prison health corporation. The doctors and nurses are on staff at H&H. And so that's one kind of like opportunity for a local health agency to be engaged in reform, or dare I say, abolitionist work. I will say once the Bureau moved over to our public hospital system, what took its place at our health department was a unit that was then focused on what are the population health impacts of incarceration, because really that's the bread and butter of a public health department, right? Like we are responsible for the population's health or whatever jurisdiction that we're situated within. And so that bureau was then focused on, okay, like how can we construct surveys now and the ways that we do, for our larger community health survey to get a better sense of what are the needs and experiences, the health experiences of people just in the population, their families, the neighborhoods that they come from. It enabled us to do a more robust analysis of the impact of incarceration in New York City. So I know we're short on time. I hope that kind of answers your question, but those are kind of the opportunities. The challenges are, as I kind of briefly mentioned, well, there's two. The one I briefly mentioned earlier on issues of dual loyalty. And then the second one is politics, right? So we, there's an understanding that like, within city government or within local government, one agency cannot be publicly opposed to another city agency. Right. So at the health department, we're documenting all these cases, or, me and, our leadership documenting all these cases of brutality. We're, ringing the alarm to, at the time it was Bloomberg saying like, hey, like, we really should not be putting people in solitary confinement. People are there for years in a local jail. You know what I mean? Any of the other kind of like issues we were seeing, but we were told you need to be quiet. Yeah. Right, because all these agencies also reflect, the person that we elected to office. So if you're coming out and saying like, here, there's all this brutality, there's all this mess on Rikers Island, that reflects poorly on the mayor who's currently in place. So politics also presents a challenge for municipal health departments that are engaged in this work, because, everyone needs to present a unified front and make it appear as though, the city, the people who are elected to office have everything under control. And I think I'm really at time, so I'm going to be quiet now.
I love it. I love it. Just so you know, we have about 15 minutes and we have a handful more questions. So just for our panelists, we're getting to the point where we already want to talk about solutions. And we're going to, unfortunately, have the shortest amount of time for that. So TJ, quickly, can you talk about the reentry process after incarceration, some dangers and really the opportunities for intervention during that period, specifically when it comes to health outcomes.
Yeah, so let me start by kind of invoking a scholar named Laurie Wakant, who's done a lot of work on the reentry front. He was a MacArthur Fellow at one point and spent a lot of time looking at the reentry process and concluded, depressingly enough, that reentry is just another big word that means exactly as Jasmine said, the same thing, which is incarceration. We have a whole nonprofit complex in place around this vocabulary of reentry, but pretty much it's punitive, it's non-confidential, and it really doesn't get to reentry. It doesn't actually engage our folks in public health or in private health or in employment or in housing that is not connected to all kinds of constraints. So with that in mind, the solution, I want to go quickly to that because that is depressing and kind of forced me as an academic as well as a social worker to kind of, get together with the person who is now our mayor. He used to, not mayor, I'm sorry, the DA, Larry Krasner. He used to be my defender. He used to be the guy who got me out of jail every now and then. And Larry Krasner's office and, some of us came together to kind of figure out both from a prosecutorial standpoint, as well as from a public health and social services standpoint, what could be a framework in Philadelphia. And from that came a center that we co-founded called the Center for Carceral Communities. And we've been able to keep about 500 people over the last few years out of incarceration and re-engaged. We've had 3 reincarceration over the course of the last, 8-9 years. For people who are reincarcerated, as you know, every 3 months. And the way we've done it is, I'm trying to finish the book on that, so you'll have to wait for that. But really quick in a minute kind of answer. First of all, we've kind of created a collective, and it has to be a collective. It can't be this one-on-one services that we all talk about that is part of the whole capitalist framework of re-engaging people into a system so that they go right back into the system. We've created a collective of people who are substance users so that they can use safely. We've created a collective of sex workers so that sex workers can, are resisting criminalization and arrests and are able to engage in sex work safely. We've created a collective of people coming out of prison. We have people who spend 20 years on death row, 30 years in solitary confinement. We've created a collective of them at the center, where we are really kind of working on something, we call it the gains intervention, where we're working individually with group therapies, individual therapy, but mostly in collective group therapy. And then also at the advocacy level, where we're working with the DA's office to kind of re-engage the entire city and community around re-engaging folks who are in and out of the carceral. So we call it the Center for Carceral Communities for a reason, because we consider the entire community to be carceral. It is one big fat prison that we, and not to be fat phobic, I'm sorry to use, I use that term in terms of it is fed by dollars. And I do not want to ignore the reality of what we're taking on. And I do believe that we have a massive public health crisis on our hands. And institutes like yours, like the way we've come together. By the way, I love the fact that in a predominantly white institution like Penn and Harvard, we have such an amazing panel of people of color. I just absolutely am vibing on that. Thank you very much for putting this together. I think these are the conversations that will help. We can't just be academics. We can't just be researchers. We can't just be public health civil servants. We have to be on the ground, collectivizing, and standing firm. We, at the center, for example, this Friday, we have folks going up in front of the judge. We will be there as a collective at that court, making sure our people are safe, because we don't trust judges. They are the most criminal of them all sometimes. They do not understand confidentiality, and the limits of confidentiality that they think are limits are not actual limits, because they routinely actually trample on legal confidentiality for our folks. So those are some of the steps, and I'd be happy to talk about it more later. Thank you.
Aja, I want to come to you quickly. So with your organization, Physicians for Criminal Justice Reform, what do you want to see? State, local, federal level, where do you want to see reform? What are the policy changes you are hoping to see?
Just started my stopwatch, so I'm gonna try and fly. So One, I need y'all to tell me. So I'd love for you all to join Physicians for Criminal Justice Reform. It's not just physicians, medical students, allies, and other health professionals. We need all hands on deck to combat this. And one of the initiatives that we have is trying to go state by state and coming up with fact sheets that talk about the bills and the local legislatures that are trying to address some of these issues, because all of this is local, right? The bills that are coming up in Georgia are things that maybe California has done 5 years ago. Broadly, if you talk about our initiatives, we are looking at decarceration, and there's bills on federal level that look at that around the COVID-19 pandemic and earlier release. There are ways to try and get the First Step Act better implemented so that people are released from the mandatory minimums they had before, to apply it a little bit more retroactively and a little bit more effectively than's been done in the past at local levels. Diversionary programs, which we're starting to gain some momentum, but maybe losing some momentum because of the local spikes in crime. Which again, the spikes in crime that are all over the headlines are nowhere near the crime we had in the 90s. We're still at record low crime levels overall, but they're using the recent crime spikes as a reason to increase incarceration and policing. Obviously, trying to decrease the violent encounters between police and society means police reform, if not abolition. And again, different localities are closer to abolition, and others need to start with reform before we're going to get there. So, research the local bills that are coming up. Reach out to us. We can talk to you about some general things that everywhere is looking for, and let's make sure that we can inform our legislators of the things that are important for health.
And just for the audience that's out there, all of these panelists are looking for colleagues to join along. So, feel free to reach out to them, learn more about how you can be a part of the process to positively influence the work that they're doing, and to be someone who is helping to move the needle forward towards addressing the reforms or the abolition that our panelists are presenting. Monique, again, trying to keep it brief. We know that this is a public health problem. What are some public health approaches to addressing incarceration, and are there models out there that we can look at to addressing this on a public health scale?
So I'll just make 2 points. One, I think central to any type of solution is centering the individuals who are impacted. And so as a public health profession, as medical practitioners, we need to provide the respect for the expertise that people with lived experience have and center our solutions on their directives, right? We need to be professions of service and facilitators rather than driving the change. So that's one thing that I would say. The other is I think we have a great model across the nation. If COVID-19 taught us one thing, it's that we can decarcerate. It can be done. So these are words that were said as kind of like, oh, that's unicorns and lollipops. You must be crazy to be thinking about abolition. It can happen. However, it has to be intentional, because as has been shared before, when we use these piecemeal and reactionary approaches, we can perpetuate racial inequities. And in fact, we've seen that with COVID-19. A recent paper that came out by Klein et al. About the changes in prison populations and the racialized differences in those prison populations actually found that the reduction in our prison populations, and this is largely true for jails, was because of reduction in admissions. However, there was a racialized reduction in admissions. And so those reductions were most profoundly seen among white Americans. And in fact, in some places, there were increase of admissions among Black and Latino individuals. So our reactions cannot be reactions. We have to be intentional, and we have to lead with the leaders. And very often we're not the leaders. And so we need to allow those people to lead us into brave spaces and allow communities to design what justice looks like for them, because communities are left out of that discussion.
Thank you. The saying of healthcare and all policy rings to mind when I hear you talking, and I think that's the direction you're going, even when we're talking about mass incarceration. Sashi, again, very quickly, what are the top policy priorities that criminal justice reform advocates should be focusing on, and how can we engage with lawmakers? Maybe anchoring on that last part, how can we engage lawmakers, especially in a topic that isn't palatable for a lot of people?
Well, first, I would like to say, as always, because Massachusetts has one of the lowest numbers of women incarcerated, yet the highest yet the highest of women serving life. So legislators, lawmakers, everybody should be really exploring clemency as an option. Immediately on the federal level and on the state level, Biden should be granting clemency. Governor Baker should be granting clemency. That's like the number one decarceration tool right now that I could think of. But Families for Justice as Healing, we passed last year primary caretakers, which is an amazing tool. We're pushing for the prison and jail moratorium bill, because if we're all talking about decarcerating, if we're talking about ending incarceration of women and girls, whether it's reform or abolition, if the system keeps building more prisons and jails, they're going to figure out how to fill them up. So we need to be really figuring out in Massachusetts how, and even further, how to implement a prison and jail moratorium bill, so that way no more prisons and jails can be built as a whole. And then also sex decrim, drug decrim, and medical and elderly parole should be top priorities. I was gonna say, when you were talking about sex work, we have to really figure out what does that look like in all communities, because I know in my community it's not called sex work, we're criminalized for that. So all of these bills that I just talked about would really get us to ending incarceration of women and girls, or just ending incarceration period, because there's no sex or gender. But I think those are the priority bills that we should be focusing on. And shout out to Jasmine and everybody that came out yesterday, because we had an amazing action in front of the State House of our prison and jail moratorium bill in Massachusetts. We're leading that work right now, and it's in the judiciary. So we're hoping that they vote favorably on it. So if you call Rep Day or Spilka right now, tell them you support no new prisons, no new women's prisons. And thank you.
Awesome. The nuggets that are being dropped in these very short statements from our panelists are absolutely amazing. And I hate that it's rushed, but I just want to really acknowledge the amazing amount of information that's being given in these 2 to 3 minute spiels. Jasmine, I want to close with you. What kind of culture changes do you see are necessary for really transforming the system of incarceration that currently exists, and overall improving health outcomes? And are you optimistic that these are going to change? I would love to end on a high note, so hopefully you are optimistic, but you see you shaking your head, so probably not, but would love to hear your thoughts.
I'll still leave us on a high note, but yeah, no, you can't. There's no culture change in systems of confinement, like in immigration detention centers and jails and prisons. They are designed to create chaos and harm. So that I'm going to leave the case for abolition. There are plenty of scholars and activists who will be making this case, but the high note for it is that abolition is not just about the absence of jails and prisons and systems of confinement. It's about the provision of systems that or rebuilding, creating systems that enable people to actually thrive. Right? It's about ensuring that people have a quality place to live. It's really the push and the imagination for systems that allow for people to have their basic human rights. We're not talking about something that's like way out and spectacular here. We're talking about just housing, food, the provision of quality care. So the abolition is something to get excited about. It's not just, again, an absence of one thing. It's about the opportunity to radically imagine a world that is different. I will say I'm already excited to see nuggets of that. One kind of pathway into the beast that is the carceral system is through policing, for example, right? Many places, New York City, New Jersey, Newark, New Jersey, and the other jurisdictions in the state of New Jersey, for example, are really moving towards community responder models, right? So it's the recognition that police should not actually be responding to a behavioral health crisis. If someone is experiencing a non-fatal overdose, it should not be a police officer that responds, but someone who has, more appropriate training, a harm reduction specialist, a social worker. If someone's experiencing, a psychiatric, kind of experiencing psychosis publicly, a trained mental health professional should be the person who responds, not a police officer. So there's both that recognition, but then also movement, right? There's the program Be Heard in New York City, which in one local police precinct enables people to call 911 and have, pure health professionals dispatched from our 911 system. And Newark is moving to a similar model in both to their two jurisdictions, Gloucester County and Elizabeth City in New Jersey, that are also considering taking up the models that were actually created by Black folks living in the neighborhood who said, enough. There's a new model, adopt this model. So community responders are something to be, or programs are something to be excited about. And I just want to quickly end by saying, I watched Brian Stevenson's True Justice documentary recently on HBO, and I really appreciate the ending of it, which reminded us that, you know, enslavement existed for 246 years. That's wild, 246 years. And at that point in time, the idea of abolition was not popular. I think a lot of people, and he says this, look back and they're like, if that was me, oh my gosh, I'd be the main abolitionist saying like, no, it's not fair for people to be subjugated to this type of exploitation and torture. But actually it wasn't popular. People were like, no, this actually makes sense. There are laws and whole systems that perpetuated and enabled it to thrive for almost 300 years. So we're in really the same moment at this point in time. And so I offer people that question and reflection of like, if you think that you would have been an abolitionist, you know, during those 246 years of enslavement, and you don't think abolition is possible today, then I encourage you to reflect and figure out how to reconcile that distance. And I'll just quiet there.
Awesome. Thank you for ending. And I think you did end on a positive note. So thank you for that. I want to say thank you to Jasmine. Thank you to Sashi. Thank you to Monique. Thank you to Aja. And thank you to TJ for being here with us. There are some Instagram and Twitter handles that you can follow if you want to learn more about the organizations that these great individuals represent. Thank you for joining us for this panel. We do have an upcoming panel on March 10th on climate change and its impact on vulnerable populations. That's going to be our next equity and social justice lecture series event, March 10th at noon. More information about that to come. You can find more information about our upcoming DICP events on our website. Again, thank you to our panelists. Thank you to the audience for sticking with us and being a part of this conversation. And thank you to all the folks working behind the scenes, Aljani, Mustafa, for helping us to pull this off. All right, everyone have a good day, and thank you for your time.